כיף, לא נורמלי. Okay, I'm switching to English. All right, we all have to disclose our conflict of interest. I think Asaf just mentioned a few. But the last one is that I'm actually now working on a project to expand what we do in the clinic to a bigger version, and this is called Ona Health. But that's still very much in its infancy. All right, so today I'm talking about the benefits of the ketogenic diet. And I'll start with an article that was published in 1961 by in Circulation, published by the American Heart Association, as a journal of the American Heart Association. And one of the things is that we were told there was a huge increase in heart attacks in the 1950s, and nobody really understood why. And they thought that maybe it was pollution, or maybe it was the increase in sugar, the increase in fat, the lack of vitamins. They weren't really sure what it was, but there seemed to be a big drive to find out why, because there were suddenly people dropping like flies, like, you know, middle-aged men suddenly, including Eisenhower, who was out of the White House for 10 days. So there was a real push to find a solution. There wasn't one, but the push was to say that it was saturated fats. So the American Heart Association published this paper, and it said that we should really watch dietary fats to prevent cardiovascular disease. But at the bottom, they say, you know what? There is as yet, it must be emphasized that there is yet not enough evidence to say this. Okay, but it was a small little line. But once it starts to be said, it starts to grow, okay? And this thing started rolling and rolling. So the point in the 1961, that was 1961, 1977, it becomes official dietary guidelines. Watch the fat. But when you make this official, this has a lot of consequences. Dietitians have to practice this way. The foods in the school have to be done according to guidelines. The military has to eat according to these guidelines. This has long-term consequences. So what do the dietary guidelines say? They said, make the base of the pyramid carbohydrates, minimize fat. If you're going to eat fat, it better be polyunsaturated. This polyunsaturated fat that you've been hearing about all day long. Polyunsaturated fat does lower cholesterol, and this is what we should be using. All right, and the Americans follow the guidelines. They actually did do what they were told. And if you look on the right, you see that it's women on the dark blue, I believe. I don't know what happened to the color. But anyway, there's men and women here. And essentially what has happened is that fat really did go down and carbs really did increase. And when that happens, when you increase carbs, you end up increasing calories actually anyway. Even though carbs have less calories per gram, you end up eating more calories because you're usually eating it with the fructose and your appetite goes up. So anyway, this is a schematic view, but it is a turning point. The guidelines are a turning point, although it was, like Chris said, something that had been happening all along. So why does this matter? First of all, a government telling us what to eat is a big deal because it wasn't based on any solid science, but there's a physiological response that's different for every type of macronutrient we eat. So when we do eat carbs, there is a large increase in insulin. When we eat proteins, there are some, and when we eat fat, I mean, this graph shows there is some insulin response, although we heard today that actually fat leads to no insulin response whatsoever. But bottom line here is that remember we've heard all day, insulin is a storage hormone, okay? We don't want to be eating and storing more and more and more as we grow. We don't want to keep growing after age 18. So we need to stop, to watch the insulin levels. Now insulin, as we said again today, insulin does a lot of things. It is most famous for lowering blood sugar, but it has pleiotropic effects. It does many, many things depending on the cell that it's acting on. So it leads to cell proliferation through some mechanisms. It leads to protein synthesis in other mechanisms. It leads to lipid synthesis. It makes fat. it actually stops gluconeogenesis. As we said, gluconeogenesis is a process of making sugar. So here we're actually storing the sugar. That's what it does in glycogen synthesis and glucose uptake. So if we look at it, if we hone in on the fat cell, what's really important to understand is that we can only store fat into the fat cell under the presence of insulin. No insulin around, we will not store fat, okay? The truth is that it's also, the opposite is also true, okay? We cannot let fat out of the fat cell. We can't use that fat. It's kept stored in here unless we actually lower the insulin level, okay? And this is controlled by a hormone-sensitive lipase. This is the rate-limiting step. So it's very, very sensitive to insulin. So again, health, metabolic health is the balance between storing and using. We need to, we have this balance in order to be healthy. We need to use and store, use and store. But what's happened is that we've lost that balance, okay? Now let's look at what normal insulin levels should look like, okay? An insulin level is up when we eat, goes down when we don't eat, pretty close to less than 4 in the fasting state. Well, 4 or 5, depending on what you want. But what happens is that through all the mechanisms that we've discussed today, whether it be the seed oils, the fructose, the carbs, the combination, because it's really what we're living in is a combination of all three. What we end up with is high insulin levels, whether we eat or don't eat, okay? We are in a complete storage mode all the time. Now, this process, which is now called insulin resistance, okay, is present in 70% of obese people, depending on what you read, 70 to 80%, but also 25% in normal weight people, okay? Probably due to the fructose and the seed oils working in the liver. So 25% of normal weight people walking around, they have no idea why they have hypertension, why they have chronic aches and pains, and there's probably an underlying insulin resistance going on there. How do I know somebody has insulin resistance? When they walk in my office, I can check things, okay? But what are the signs and symptoms that you can look for? One is weight gain, okay? So first we put the fat subcutaneously. We store subcutaneously. It's supposed to give us cushion. This is good. If we have a lot of subcutaneous fats, we're not gonna get metabolically sick if we have a lot of these adipocytes. The problem is when we start storing in other places, like visceral fat. And this fat is not healthy. This fat is metabolically active, okay? Exactly as you heard already a few times today, when you can't put fat into little fat cells, and the fat cells now stop, you have the pre-adipocytes, which are the stem cells that then eventually become fat cells. When you stop that process from happening, then you are not able to bring in new fat cells. And that means that now you have to do with the fat cells that are there. And they get overstuffed. And those stuffed fat cells do exactly what Ben is talking about, okay? They become hypertrophy and Rafi. We've heard this all day. I'm just repeating what you've heard all day, okay? These over-fat stuffed cells are causing inflammation, okay? They're causing a lot of issues here. And they're just very biologically active. Now, the leaking out of the fat, the triglycerides, is coming from the fact that we can't contain this fat anymore. So the triglycerides, we see that easily in every lab test. Usually with high triglycerides, you see low HDL, mopping up the high triglycerides. Low HDL, the most predictive marker of cardiovascular disease, low HDL. Hypertension. Hypertension is very, very strongly linked to high insulin levels, okay? For example, here you see a study where they took people without any hypertension, they measured their insulin levels, and they followed them over time. Over time, those who had initially high insulin levels developed hypertension, okay? So, and we see also, once we lower the insulin levels, the hypertension improves and we can take the meds off. So basically, and the last point is dysglycemia. The pancreas is working really hard, secreting all this insulin. Eventually, in about 10% of these people, diabetes develops. It's the least common symptom, okay? So people think that they're just looking at the high sugar. No, only 10% of people with insulin resistance have diabetes or dysglycemia a little more, but frank diabetes. So dysglycemia can be because the pancreas, why does the pancreas stop working? We have a few reasons, competing theories. One is that actually we find a lot of fat in the pancreas. And when there's fat in different organs where it shouldn't be, the organ doesn't work as well, okay? But there are other reasons as well. It's a complex issue, but the bottom line is in 10% of people, the pancreas does not keep up, and then you have the sugar rise, okay? So this is a graph that I learned about this from Ben Bickman, actually, done by a mentor of mine, Ron Kahn, at Joslin, and they followed people for years, okay? For 20 years, they followed patients that did not have diabetes. And always, they found that type 2 diabetes is preceded by high insulin levels. And the insulin levels are high at the time of diagnosis, okay? This is, again, I'm repeating myself over and over again, what you heard today. Type 2 diabetes is a disease of too much insulin. We're just not responding to it. So diabetes is a severe symptom of metabolic syndrome. What are other symptoms? It's clear. People come in saying, I'm hungry all the time. I can't control myself. I don't have willpower. I'm weak, okay? This is just a symptom of insulin resistance. These people are not weak, okay? They're strong individuals. It's just that they're hormonally driven to eat more. And in part, I think my slides are all messed up, but that's all right. You guys can read it. Leptin, as was mentioned this morning, is playing a big role here, okay? Because leptin is inhibited by insulin, and high levels of insulin make leptin not work. So then you don't get the satiety that you should be having. So we care about this because these signs and symptoms later translate into real disease, okay? And mostly I'm going to say cardiovascular disease, but actually the list is super long. We see high insulin levels with just about all the chronic diseases of this century. So, and we have known this already since Gerald Reaven in the 1980s, who did extensive research and looked at this in great depth. So one other interesting thing is that hyperinsulinemia itself, without all these signs and symptoms, without the high triglycerides and low HDL, without the hypertension, which in and of itself are all causing problems, the actual insulin is a growth hormone, and it's causing growth at the plaque, at the actual level of the vessel. All right, so just to show you one of many, many studies, this is a study done by Gerald Reaven, prospective study, 600 people, followed for 13 years, okay? This is, the kind of study you like to look at. And this study measured insulin at the beginning of the study. Nobody had cardiovascular disease. If you had high insulin levels at the beginning of the study, 13 years later, you were much more likely to develop cardiovascular disease. And studies like this, prospective, really well done studies, some followed up for 22 years, are showing the same thing. So what is my goal of treatment? Our goal of treatment is let's lower the insulin, okay? Everything else will follow. Let's lower the insulin. And there are many ways of doing that, okay? So because insulin resistance is not 100%, as you can see, we keep talking about the various causes of it, and it's a complicated issue. But bottom line, I gotta lower that insulin. So fasting, it's a fantastic way of lowering insulin. Don't eat. That doesn't trigger the insulin response. Over time, it will go down, okay? So yes, fasting is a really powerful tool, but since we have to eat, what are we gonna eat? Well, actually, the ketogenic diet has been shown to be the most effective way of lowering insulin levels. And when I say the ketogenic diet, it's a very vague term, actually. Today, we just now heard a lecture on PKD, which is the most extreme version of the ketogenic diet that I know of, okay, which is really a plant-free diet, completely just animal and organ-based. But it is also a sort of ketogenic diet. So ketogenic diet is kind of a wide term, and there are many discussions on that, and that's part of the individualization, of the personalization that must be done with each patient. So we want to lower that insulin. So why is this called the ketogenic diet? It's called the ketogenic diet because this is when ketones in the blood go up. So it also happens with fasting. Basically, it happens when we don't burn carbohydrates, okay? So the body can use basically two types of fuel, either carbs or fats. Protein is mostly used for building. Fat is also used for building. Carbs are only used for quick energy. So when we eat a diet that's protein and fats, then actually we start using fat for energy, okay? We cannot use fat for energy if carbs are around, okay? The body will preferentially burn carbs. Only if carbs are not around, we will start to wake up those enzymes that actually metabolize fat and start burning fat. So the problem is that these fat molecules don't go in through the blood-brain barrier into the brain. And the liver cuts them into, metabolizes them to smaller pieces called ketones. And ketones do get into the brain. So one of the issues in medicine is that doctors confuse the word ketosis with ketoacidosis. And this is two extremely different things. Ketosis is a natural state that is probably part of our human evolution, and we've have been, in fact, Veach, who's one of the major researchers in ketones, said this is probably our baseline state, to be in the state of ketosis, and usually it's defined between 0.3 or 0.5 to 2.53, okay? So this is a state where you're being fed by ketones, but there's still a low level of insulin in the background. There always is a low level of insulin in the background. What happens in ketoacidosis is that there is no insulin. This is type 1 diabetes. There is no insulin. Now you have uncontrolled fat burning, okay? You're just oxidizing fat like crazy. And the ketones are acidic. This changes the pH in the blood, and then you get really, really sick. This is an emergency, and you need insulin, okay? This is the difference between ketosis and ketoacidosis, and everybody needs to understand that, because the doctors go, no, keto. No, okay, there's a difference. So, must we be so extreme? A lot of people say, come on, what's wrong with fruit, and what's wrong with a little rice once in a while? And it's true, it depends on your condition. But if I want to burn fat, yes, I have to be extreme, quote unquote. Once you live this way, it doesn't feel extreme. But yes, you have to lower the insulin. Why? Because I'll remind you that, remember that hormone-sensitive lipase, that enzyme that allows the fat to leave the fat cell and be used for energy, it's extremely sensitive to insulin. The minute that insulin goes up, you will not burn fat, okay? So you stop that process. Why? Because if insulin is up in the normal condition, that means that there's food. Why would we use our precious fat that's there for a rainy day if there's insulin around, meaning that there's food around? But of course, insulin resistance is a pathological state. All right, so does it work? Yes, it works, okay? So this is just a picture of meta-analyses looking at randomized controlled trials. And let's look at weight loss, just as one of the symptoms of metabolic disease, fat. So when we compare weight loss, we have on the left low carb, on the right low fat. And actually, low carb does better every time. The thing is that a lot of studies, even that are included, say, you know, we're not going to compare. Let's take, for example, the Gardner study. It's a study that's in the middle, 2007, okay? It's a study done by a Stanford professor that compared low carb to low fat. But in the methodology, after a few weeks, they start adding back carbs every week by 5 grams, okay? So the study is a year long, but really, we're not really comparing the two diets. The effect is really, really powerful in the first few months, but afterwards you see that actually the difference is not that big. But the reason is because in the methodology, we stopped comparing really a low-carb diet to a low-fat diet because we started adding back in the carbs and actually in the fat. So it's not really comparing the two diets. So this is a big problem that I've run into a lot of trials, which is that we are not really comparing the way we think we're comparing if you just read the title. Okay, when you look at ketogenic diets, and they are definitely by far the most effective at curing the metabolic syndrome. The symptoms being weight, okay? In the pink on the right, you see the ketogenic diet. You see the cereal diet in the orange on the left side, okay? So it's the ketogenic is the most on the right. And for every single parameter, be it weight, be it glucose or A1C, which is essentially the same thing, being HDL and triglyceride, we see the triglycerides drop, which is what we want. The HDL goes up, which is what we want. And of course, we have the rise in LDL. But remember that LDL is not part of the metabolic syndrome, okay? So yes, in more than a third of cases, the ketogenic diet increases LDL cholesterol, which is really what brings us to a huge conflict with all of the medical establishment. And it's a very complex issue, and the more we learn about it, the more I agree with Rafi that it's probably most related to the oxidation that happens because of the linoleic acid on the LDL. Because what happens is that when we are in a metabolic derangement, okay, when we have metabolic syndrome, our LDL becomes small, okay? So we call small LDL, we call it pattern B, okay? So on the right we have pattern A, and on the left we have pattern A, which is a normal metabolic condition, and on the right we have pattern B, which is a metabolic syndrome. And what happens is that the LDL is not reabsorbed, it doesn't go back to the liver, it's not cleared out the way it should, and it hangs around and becomes smaller and smaller. And also, it becomes oxidized and many times glycosylated, meaning sugar sticks to it if you're a diabetic. This is one of the reasons why you're much more prone to a heart attack, but as a diabetic. But bottom line is that the pattern becomes unhealthy. And what the ketogenic diet does is that it switches back the pattern B to pattern A, okay? And we've seen this in many trials. And the pattern A actually is just bigger diameter, okay? And one of the things that happens is that because LDL is a calculated number, when you see it's called LDL-C, because it's actually calculated, what they're calculating is an area. This area expands because each particle expands. And so in general, what happens is that we have an enlargement of the area. So LDL does go up, but it's the pattern A. Now, this is in general, but then you have to look at each case individually, okay? Because until the metabolic syndrome is not cured, okay, you're still, I think, at risk for having a pattern B. So if we just look at the study that put people on a ketogenic diet or a low-carb diet, this was actually done by Parker and Jeff Volek and Steve Finney. I think it's a very beautiful study. And what they saw is that the LDL diameter increases. So you have on the left, you have the baseline, and then you see that the low-carb group, the LDL diameter increases, and on the high-carb group, low-fat group, the LDL diameter stays small. And also what you see is that when we eat fat, the more fat we eat, the less fat we have in our bloodstream, okay, when we take away the carbs. So this is why eating fat does not lead to fat in the blood, okay? This is like basic things that we think, okay? I eat fat, I get fat, first of all, one of the things people say. Another thing is, I eat fat and I'm gonna have high triglycerides. But wait a second, you're telling me to eat fat, I have high triglycerides. Well, it doesn't work that way, okay? We need to teach the body how to use that fat. And the only way to teach the body how to use that fat is to take the carbs out. Because remember, you can't burn carbs and fat at the same time. You can only burn fat if there are no carbs around. That's how the triglycerides go down. All right, so the American Heart Association finally took note, as Rafi mentioned earlier, and the American Diabetes Association, and they both started to admit that this is a very powerful diet and we should be paying attention. This was the work of a lot of lobbyists trying to just look at the studies, okay? And we're still not there, we're not there. The dietary guidelines are still not there. They're not reviewing all the evidence. Okay, so these are the the benefits, such as weight loss, lowering triglycerides, increasing HDL, lowering blood pressure, and improving glucose. Okay, so that's great, but there are other things too. So when you eat fat and you have fatty liver, the first question everybody asks me is, how can you tell me to eat fat? My liver's already full of fat. Same concept, okay? You lower the fat and quickly because you are learning to use fat for energy, okay? If we look at this is a study actually with biopsy of livers. It's not about the weight loss, okay? Any diet, any weight loss will improve fatty liver, but a ketogenic diet will improve it a lot more. And so here you see on the right, the hepatic triglyceride change in the biopsy, in the actual liver, decreased much more on the ketogenic diet versus a low-fat diet. So it also decreases inflammation. So remember when we talked about these little funny things called ketones? They're not just food. They're not just a small fat. They're actually signaling molecules, okay? And this is why they're so fascinating to me, because they actually go into the nucleus and they actually change genes, okay? So nutritional ketosis also enhances cellular defense against oxidative stress and are anti-inflammatory signaling metabolites, okay? For example, here, this is a paper that shows that ketones basically block a mechanism called the NLRP3 inflammasome, which mediates inflammation, and the ketones actually are able to modify that, which is why we see all the interesting benefits that we heard about in the last lecture. I mean, this is fascinating stuff, where you start to see that this is not just a fuel. It is also having incredible amount of effects throughout our whole body. And one of them is also improving sleep, okay? Here's a study. This is from the Virta trial, okay? Virta is it's a company that provides treatment for low carb, for diabetes, and now they're expanding using the ketogenic diet. It's an amazing company, and they are using, and they're doing a lot of trials on this data as it comes in, and one of them is on sleep. And you can see that the people who are diabetics on keto, this is a questionnaire that's called the Pittsburgh Sleep Quality Index questionnaire, and basically what you care about seeing is that the bar goes down, okay? You want to improve, okay? You want the lower number. So on the left, you see the diabetes group on keto. On the right, you see the diabetes group on the American Diabetes Association diet. And in the Diabetes Association diet, sleep gets worse. It also decreases hunger, okay? Because we're lowering that leptin. We're not lowering leptin, we're letting the leptin do its job, okay? But there are many other hormones at play here, okay? I won't go into details, but for example, it increases GLP-1, Ozempic, GLP-1, okay? The diet increases GLP-1, okay? There are many other hormones involved here, but basically, you're being fed by your own fat. That to me is enough to lower the explanation of why we're not hungry, okay? But there are many hormones here at work. So also, besides all that, you're increasing your energy levels. Now, here's a study by David Ludwig from Harvard, and they actually did a great study because they fed people the food. So this is the kind of study you want, where you actually know what's going into people's mouths. So people who actually, they divided into three different groups. This is low carb, it's not keto, okay? Low carb, which is 20% carbs, 40% carbs, or 60% carbs. 60% carbs is the low-fat diet. So what happens is that actually you see that the energy expenditure goes up in the low-carb group, okay? You become more efficient at creating ATP. And it improves mood, okay? And there are many, many interesting trials, and I'm actually now doing a review for a paper on depression in ketogenic diet. It's very, very interesting how the brain likes stability, and it loves the anti-inflammatory ketones, and you hear people feeling better. But here's, for example, is a study on depression. And this is, they use a scale that's like standardized for depression, and you want the lower number, okay? So at baseline, it's 9.4, and then at 10 weeks, It went down, and after 2 years, it's still lower than where we started. So here's another way to control our general well-being. So there are many interesting ways of many things to think about, and the research that needs to be done in this field is enormous. But let's just go through examples of things, okay? So colitis, okay, as we were just heard about, colitis, polycystic ovarian, rheumatoid arthritis, autoimmunity with multiple sclerosis, refractory epilepsy, neurodegenerative diseases, Alzheimer's disease, dementia, lots being done in this area. Cancer treatment, because of the whole idea that cancer might well be a metabolic disease. And even lifespan extending properties of these ketones, which we see in animals, but we haven't tested this in humans and probably never will. So the thing is that there's a lot to research, but it is a very exciting field. And I think with that, we're finishing. So, bekitsur, 50 years or more that we're being told to eat a low-carb, high-fat diet. We're not doing so great with this, and the rates of metabolic syndrome are just increasing. The signs and symptoms are basically abdominal obesity, hypertension, high triglycerides, low HDL, and high glucose, which all of them are predisposing us to heart disease. When we say metabolic syndrome, we just mean insulin, okay? High insulin. And the ketogenic diet is the most efficient way I know of to treat this. That's it. And thank you to my incredible team. I couldn't do this without you.